Recording in progress.
Typically, I wait 2 minutes after the start time to begin, just to allow people to funnel into the room.
Yes.
All right, well, good afternoon, everyone in North America. I'd like to thank you for participating in our monthly Global Journal Club brought to us by the World Federation of Athletic Training and Therapy. My name is Dr. Jake Resch. I'm at the University of Virginia. I'm also the marketing chair for the World Federation of Athletic Training and Therapy. More importantly, we have a guest today from the Netherlands. So Dr. Sabine van der Graaff is joining us to discuss our article of choice for this month. So Dr. van der Graaff, welcome to our journal club.
Yeah, thank you. Thank you for inviting me. It's a pleasure to join your journal club. It's very nice.
Well, it's absolutely our pleasure. I'm really excited to break down the really important work that you published in the last year or so regarding those individuals that decide to pursue or not to pursue ACL reconstruction. So before we begin, I do want to give a brief bio for Dr. van der Graaff. So Dr. van der Graaff finished her medical studies in Rotterdam at the end of 2019. Then Dr. van der Graaff started her PhD project at the Department of Orthopedics and Sports Medicine of the Erasmus Medical Center in Rotterdam. Dr. van der Graaff's PhD project focuses on optimal treatment strategies for patients with traumatic meniscal tear or an anterior cruciate ligament rupture. From the end of 2021, Dr. van der Graaff started working as a medical doctor to develop her clinical skills. In the future, she is planning to apply for a residency program to become an orthopedic surgeon. So again, welcome to our journal club today, Dr. van der Graaff. So I'm going to stop the share. I'm actually going to do a new share with the article of choice. So bear with me, those that are joining us online. All right, so as I mentioned, we're going to break down Dr. van der Graaff's important contribution to the ACL literature. And really, it's a relatively hot topic for those individuals that want to pursue or not to pursue ACL reconstruction. So I'm going to kick things off here. And for those that are joining us for the first time, we want this to be interactive. We want this to be a forum where if you have questions, Dr. van der Graaff is absolutely okay with you interrupting her to ask your question. But if you feel more comfortable, please feel free to use the chat function in order to type your question into the chat, and I will get to it accordingly. And in terms of the netiquette that was on our slide deck prior to the start of the journal club, I promise you I will be breaking about every one of the rules of netiquette when doing this journal club. So with that being said, I'm going to kick things off. And Dr. van der Graaff, why do you feel like this topic is important?
Yeah, I think it's really important to I mean, in some cases, a certain treatment is given to patients for over years, and it's never ever been questioned, like, is it really good for every patient to give that treatment? And I think that's why initially the compare trial was performed at my department. So that was to check, like, patients with ACL ruptures, can they also be fine with non-operative treatment instead of ACL reconstruction? And then in that trial, we saw that like half of the patients that started with non-operative treatment actually needed an ACL reconstruction during the 2-year follow-up. So that made us thinking, why were that patients in need for a reconstruction? What were the reasons? What were their symptoms? Like, what were the reasons that they decided, okay, I need to pursue with an ACL reconstruction. I cannot do it with rehabilitation therapy alone. So I think that was the main reason.
So Dr. Van der Graaff, from your experience, why would someone delay the reconstruction of the ACL?
Yeah, I think because, I mean, in the Netherlands, current practice is that first patients get 3 months, or a certain period of time of rehabilitation therapy first to like get the need to rest. So the swelling is over and the reaction after the trauma is over. And then some patients are actually fine with physical therapy alone. And I think in that way you can prevent that some patients get a surgery that they don't really need, or you can get to distinguish what patients need surgery and what patients would doesn't need it. So that can be a reason to delay it. So to get the need to rest a bit and to decide if patient really needs an operation or not.
So this particular study falls within the COMPARE trial. So this is a randomized controlled trial within the COMPARE trial. I was wondering if you could provide us a little bit of context of what is the COMPARE trial? What are the overarching goals of the COMPARE trial?
Yeah, I mean, the COMPARE trial is a randomized controlled trial with in total 167 patients with an acute ACL rupture. So I think it was within 6 months after the trauma, they could be included. And then we randomized these patients between early ACL reconstruction, that was within 6 weeks after inclusions, they had to get an ACL reconstruction. And the other randomization arm was rehabilitation therapy plus optional delayed ACL reconstruction. So that therapy was first 3 months of physical therapy. So they were referred to a physical therapist and got this exercise program and did the rehabilitation program for at least 3 months. And after those 3 months, if they needed it because of symptoms like instability or anything else, they could decide together with the orthopedic surgeons to get a delayed ACL reconstruction. So that were the two randomization arms, and we followed those patients for 2 years. And the primary outcome measure was the IQTC score after 2 years. And that paper is published, I think, last year in the BMJ, British Medical Journal.
And so really the primary goal of the COMPARE trial is simply to look at those individuals over time that decided to pursue operative treatment or non-operative treatment following ACL tears.
Yeah, so they were randomized into one of the two groups, and then in the early ACL reconstruction group, all patients got an ACL reconstruction, and in the rehabilitation plus optional delayed reconstruction group, like half of the patients in the end got operated and the other half didn't, but it was first randomized into the two groups.
So Xavier Thompson's one of our attendees, Dr. Van der Graaff, and Xavier, if you wouldn't mind unmuting yourself, I want you to elaborate on the comment you put in the chat. So Xavier, in the chat, you put, that's so interesting, the standard of care here in the United States is very different. Do you care to elaborate on that?
Yeah, so again, thanks for coming, Dr. Van der Graaff. So I was just talking to an athletic trainer here who's a bit more into the basic science and physiology than I am. And one of the discussion points we had was, is some of what we see here due to the surgery rather than the injury? Just because in animal models, the quadriceps recover so much quicker. But there really aren't studies like this in the United States, because generally the standard of care is to go to surgery as soon as some of that initial swelling has subsided. People might go to physical therapy for up to 2 to 4 weeks, but definitely not a period as long as 3 months. And I do wonder how that would change some of our outcomes.
Yeah, that's really interesting that you mentioned that. I was aware that treatments for ACL rupture is not, the same all over the world, but I think also in Europe it's mostly more towards this first period of physical therapy and then deciding to operate or not. I think that's based because the two big RCTs that have been conducted on this subject were the Canoon trial that was already published in 2010, was more or less the same question as the COMPARE trial, and then we had the COMPARE trial that showed also the same results, that first rehabilitation therapy is also fine if you look at the 2-year clinical outcomes. So I think that's the reason, but there are only two large RCTs, and I think in medical science, it takes always a lot of time to change current practice based on evidence. That's hard.
Especially when you look at evidence-based practice, I think the going number of years it takes to take the best research evidence and incorporate it into medical practice is around 17 years. So absolutely. So thank you very much for Xavier for your question, and also Dr. Graaff in terms of your providing the context for the study. So I found your methodology interesting, and it makes sense after you explain the context. And really the thing that I find interesting is typically when we think about ACL reconstruction or rehabilitation-based research, we think about measures of strength, measures of range of motion, et cetera. Your outcome scores were primarily based on patient-reported outcome measures. I was wondering if you could briefly describe the measures you elected to use in this study, but then also why more functional measures were not used to complement the patient-reported outcome measures you chose.
Yeah, okay, thank you for your question. First, I think it's also a practical reason. I mean, if you design this RCT, you have to determine beforehand. So before you start a study, like which outcome measures are you going to measure and at what time points. So in the COMPARE trial, we had the patient-reported outcome measures at a lot of time points. So at the 3, 6, 9, 12, and 24 months. And we also had the strength measures and some laxity measures, but those had to be carried out into the hospital, and those were only taken at baseline 12 months and 24 months. So we don't have those data like at many time points as the patient-reported outcome measures, because those were questionnaires and you could just send them online a lot at a lot of time points. And I also think it's hard to correlate, like for example, if you measure instability with a certain kind of measure, then it's hard to correlate that to the instability complaints the patients actually experience. So it's not always one by one. So I think that's also why we chose to do the patient-reported outcome measures instead of the more like objective measures, because those measures do not always correlate to the instability a patients experience.
That's great, thank you. And so for your outcome measures, you chose the IKDC, you also did the Lysholm, you did a Tanger activity scale, but then you also used the numeric rating scale for pain. And I think it makes perfect sense if you think about the context of the study that you provided. But you know, as we will continue talking, when we look at your results, it's really interesting what the patients reported in both groups, as the operative treatment group or the delayed operative treatment group got closer to the intervention versus the non-operative group as well. And we'll flesh that out a little bit later in our conversation. I do have a question going into your sample here. I'm going to focus in on table 1. One of the questions that I have, and I'm not sure if our attendees had as well, is, you know, if you could talk about who your participants were in terms of activity. Were these individuals, when they tore their ACL, was this primarily due to like intramural sport or activity, like sport in general, or where were these individuals coming from that were included with in your samples?
Yeah, I think most patients injured their ACL during sports. I mean, in this table, we only show them the one randomization arm, namely the rehabilitation plus the optional delayed ACL reconstruction. And in the main paper of the compare trial, you also have the early ACL reconstruction arm. But because they are randomized, the percentage of patients that injured their ACL during sports was more or less the same. And like level of sports, it depends. There were some really high level athletes from professional soccer or those kind of things, but also more the like amateur sport patients. So I think it's very varied. I mean, we also, we have just one kind of hospital in the Netherlands. They're all like with the health insurance, so not a lot of private clinics. So I think we got a good mixture of different kind of patients.
Great, thank you. And looking over your table, and this is a takeaway for students that might be listening in. If you look at the clinical assessments that were performed along with MRI, the Ligament was positive in both groups. It had a 100% positivity rate in both groups, which I thought was really interesting. So further evidence supporting that clinical assessment. So going in a little bit deeper, and please, for those that are attending today, if you want to interrupt and ask a question, feel free to do so at any time. Asking a little bit more about the sample, what was the primary mechanism of injury for your sample? So were they, when you look at the group F overall, for the operative and non-operative groups, what was the primary mechanism of injury?
Yeah, I think it's mostly, I don't know by heart, like all the reasons, but I mean, in some cases, patients also didn't know what exactly happened. But if I have to say, I would say it's most rotational trauma, like during soccer with the pivoting sports. So most of the times it's that the knee rotates while the foot is staying on the ground, and then the ACL ruptures.
But it wasn't necessarily like a motor vehicle accident, sports,
Yeah, mainly
other
sports. Mainly
Okay.
sports.
Okay. All right, excellent. So in terms of your results, I'm going to fast forward here. I thought it was interesting that you go on to discuss that roughly half of your operative group, but then half of your non-operative group went on to have ACL reconstruction within the 2-year study period. Did that surprise you from the non-operative group standpoint?
You mean if I'm surprised if some patients can also be fine with non-operative treatment, or?
But okay, so let me ask the question a little bit differently. So you had your delayed ACL reconstruction group, but you
Yes.
also had your group that was assigned to the non-operative group, more a conservative management through rehabilitation, et cetera. And you report that roughly half of each group went on to have ACL reconstruction within the 2-year period. I was wondering, for specifically the non-operative group, did that surprise you that those individuals then went on to say, no, I want ACL reconstruction?
Yeah, I think you have always patients that actually need a reconstruction or have this high desired activity level that they cannot do without their ACL. But maybe the numbers are not that clear in this paper, but in total we had 167 patients. And of those, like half was randomized to the early ACL reconstruction. Those patients are not in this paper. And there were 85 patients, and then 82 patients were randomized to rehabilitation plus optional delayed. So the delayed was optional, so they were not randomized to delayed reconstruction, but it was an option. So all these patients in this article, so the 82, started with non-operative treatment for at least 3 months, and then they had to decide if they needed a reconstruction or not. And then of the 82 patients, 41 got the delayed ACL reconstruction. So is it clear how I explain it?
Thank you. That does clear it up a bit more. I apologize. That must have been my misunderstanding of the
No, it
methodology.
doesn't. Yeah, it's
And
probably because of the paper. The main paper is also that has a flowchart that's more clear, maybe.
so fair enough. And looking at figure 1 here, that's on the Zoom window, you can see that the majority of that those individuals that went on for ACL reconstruction had it done within approximately the first 3 to 6 months. And you discussed that also in your discussion as well. So you follow these individuals for 2 years, right? And you've already talked about the complexity of doing an RCT or randomized controlled trial. What issues did you face over this period of time when working with a sample? Were there barriers that you faced? Was it difficult to stay in contact with these participants?
Yeah, I myself was not like really involved in conducting the study, because when I started my PhD, the study had already, like, the data was already complete. So the last follow-up of the last patient was completed. But what I faced during like searching through the data was really to, like, you have all the questionnaires and the answers, but what you really want to know is, why did this patient needed an ACL reconstruction? And if you could ask it to them, it would be great, but you have to do it with like the data and the medical records. And I really searched through all the questionnaires. Like, I mean, in this paper, we report only the IQDC, the pain, and the Ligament questionnaire, but I looked at a lot of more questions and questionnaires to see if I can find a reason why they proceeded to surgery in the end. So I think that's the hardest, to get your story, or search through all the data. That's difficult. And there are also patients, because in figure 1 you have this one patient that got the ACL reconstruction within 3 months after inclusion, and that was a protocol violation. So that's also very hard. I mean, you say to patients and they sign to like adhere to the RCT setup, but you always have protocol violations. That also makes it hard to present your results.
And specifically, I think that patient you mentioned had operative treatment within 2 days. So again, that I found it interesting. That was a protocol violation. The second thing is that individual had a second opinion and underwent operative treatment. Xavier, you have a question?
Yes. Along those same lines, I wonder how many of these, I think there might have been 2 protocol violations I saw, and both were related to them either going to hospitals outside of your RCT or different physicians. How often do you think these decisions are made more physician-centric? How do I say this? Rather than patient-centric. So do you feel like there are certain physicians who, no matter who they see, they're going to say you should get surgery? Or
of course.
Okay.
Yeah, I definitely think that. I think also, like, when I submit articles to certain journals, it also depends what kind of reviewer you get, how much operation focused they are. So also some countries have more, like the US is more focused on like get the operation soon and it's better, and more in Europe it's more conservative, like first try rehabilitation therapy. But also within the Netherlands, actually, it can also depend. If you go to this doctor in one hospital, in my hospital, they will definitely say just try physical therapy first and then come back later to talk about surgery. Well, in a private clinic or something, when there's also a money aspect, they would say, no, you definitely need surgery right now. So that's the best for you. So that doesn't matter. Yeah, for sure.
Right. Xavier, thank you for your question. And I'm going to go a little bit deeper into the results. And I'm trying not to make anyone symptomatic with scrolling up and down on Zoom. But I wanted to talk more about your patient-reported outcome measures and the outcome scores, especially with this Venn diagram, between those that went with a non-operative treatment group versus the delayed ACL reconstruction group. So 41 in each group. And I'm looking at some of these values, and I see the delayed ACL reconstruction group had some individuals flag on the IKDC. And across the board with increased pain and subjective instability, I'm really curious about the non-operative group. It seemed like they were faring much better, and that maybe just simply lent themselves to, not undergoing surgery, right? So I'm wondering if you can kind of talk about these two Venn diagrams and lessons learned from the data.
Yeah. So at these Venn diagrams, we see the baseline values from the both groups. And it's important to know because these two groups of 41 belong actually to the group of 82 that was randomized to one of the treatments arm of the compare. So yeah, these two groups are selected because during the 2 years, the first 41 did not choose for surgery and the other 41 needed surgery. But if you see the Venn diagram on the left from the non-operative group, in total 33 patients have an IKDC score below 60 at baseline. So that's at the moment of inclusion. And most of the times it was within a few months after the ACL trauma. So when they ruptured their ACL. And then the delayed reconstruction group, there are 27 patients with a low IKDC. And then, in the overlapping areas, that is for example, in the non-operative treatment group, the 4 patients, that are 4 patients with both an IKDC below 60 and a pain score of 3 or higher at baseline. And then 26 patients have all 3 symptoms. So they have a low IKDC, a high pain score, and subjective instability on the Ligament questionnaire. I think this figure was mostly to show that at baseline, there are not that many differences between the two groups, but those differences appear during the follow-up period, as you can see in the later figures.
Okay. So when looking at, to me, one of the more interesting pieces of this paper, and I think it's all really interesting, but 2 figures that really caught my eye were figure 4, right? And then I'm also going to ask you about pain, but I'm looking at this figure, I look at IKDC scores, so a higher score is actually better, right? And so we have our non-operative treatment versus our delayed ACL reconstruction group. And I see the IKDC score is improved over the delayed ACL reconstruction. And so it's important to note in your methods, you talk about this, that at the time when someone actually underwent ACL reconstruction, they did not complete the patient-reported outcome measures beyond that time point, but beyond surgery. So
yeah,
that's
they
why
did complete it, but they did complete the questionnaires, but I didn't include them in this table, in this graph, because you always see that patients have very low IKDC score right after surgery, because then they cannot move and their knee function is bad. But so to exclude that effect, we exclude the patients after their surgery. So it's only data before the surgery indeed.
So leading up to the surgery, right? So the point where what I'm referring to is, if you can see my mouse, you can see this downward trajectory for IKDC scores for the delayed ACL reconstruction, where the non-operative treatment group seem to increase and just kind of plateau roughly about at like an 80. I was wondering if you can give your thoughts on that, because I find that interesting. I mean, to me, is this a indicator that the IKDC is a good indicator of the necessity of surgery? Or is this indicator saying like the more conservative non-operative treatment through rehab might at least achieve a value that leads to some functional capability if you even have a non-repaired ACL? Like, how do you view these data from your perspective?
Yeah, I think what we can here see is maybe one of the reasons that patients that needed delayed ACL reconstruction, needed the surgery, because over time, their knee function represented by the IKDC score is not improving as you would expect, because over time, when you do rehabilitation therapy, you would expect that IKDC score will increase, as we see in the black non-operative treatment line. But in these patients, the IKDC score does improve a little bit in the beginning, but then decreases again, and that maybe can indicate why these patients needed the reconstruction in the end, because their knee function was not what it should be like, and that's maybe the reason why they proceeded to surgery.
I just find that interesting. It's almost at an inflection point where you can see where one group did relatively well with the more conservative management. And then as soon as the other group started seeing that downward trend for the IKDC, it was a point in time where operation was imminent.
Yeah, I think that's right. Yeah, it's also, we have to be a little bit cautious with this figure, because as you can see in the table above, is at every time point are less patients left, because then from the 41 patients, a lot already had surgery, so then they were excluded from the figure. So then the confidence interval also increases, and it doesn't represent the results of a lot of patients anymore, but I think it still says something that their knee function is staying behind, kind of, and that's why they proceed to surgery.
Great. Excellent. And as I mentioned earlier, maybe I skipped right past it. I apologize for that. I think you saw a similar trend with pain. And this is just my faulty memory. I thought there was a figure that went with it. But you also indicated that pain was also lessened with a non-operative group, where it increased with the operative group over a period of time. And the idea is potentially the same, is that where you start to see this increased symptomology associated with the torn ACL might be a good indicator of it's time for surgery. Is that how you would interpret that as well?
Yeah, I think, definitely. This, you remembered correctly, the pain was described also in the article, but the figure is in the supplementary, because HSM only allows certain amount of figures in one paper. But if I can describe it, it's fine. If with pain, you also saw that first in the beginning at baseline, in both groups, patients have pain. That's makes sense, because they just have an ACL rupture that's painful. But over time in the non-operative treatment group, we see that the pain scores that patients report decrease over time to a level of maybe NRS score of 1, which is not a lot of pain. But in the patients that actually needed a delayed ACL reconstruction in the end, you see that pain actually increases over time to scores about 3 or 4 on their NRS scale. So that's a certain amount of pain. And that's actually really interesting, because not a lot has been reported about pain with ACL ruptures. You'll always hear about instability or giving way complaints, but never about pain. And that was something what we were actually also surprised by, that we found that these patients that needed a surgery in the end had more pain than patients that did not need surgery. So this could also be one of the reasons why they proceeded to surgery.
Point. So going on to your discussion, and please, for our attendees at any moment, if you have a question, and it looks like, speaking of questions, it seems like Xavier has a question.
So I think we've talked a little bit about some of those indicators potentially being pain or a loss of function. Did you find, and actually now that I think about this is probably in the table, but a particular inflection point that you would say is probably around the time most people generally knew that they were going to elect to have surgery, those who did elect to have surgery in that time period?
Yeah, it's good that you mentioned that. I think it's hard to say when is really the time point that you can say, okay, this patient doesn't need surgery, never, and this patient will need surgery. Because if we go back maybe to figure 1, you see that there's peak in the number of patients that got the delayed surgery. So that is after the 3 months of rehabilitation therapy. So you could say 3 months is this inflection point, but we also have to keep in mind that the mandatory period of rehabilitation therapy was 3 months. So after this period is over, you always have these patients that were already like preoccupied a little bit by surgery, for example, that said, yeah, now I finished those 3 months, now I want my surgery. I follow the protocol. So that's why you see this peak. And I think it's true for most patients that you will need it. You will know if you need surgery within maybe 3 to 6 months after you started the rehabilitation therapy. But there are also patients, as you can see in the figure, that got the surgery actually 15 months after their inclusion, or even 24. So you will never know if a patient will need the ACL reconstruction. At what time point? It can also depend on a patient activity level. Maybe in the first 2 years, a patient is very easygoing, doesn't perform any sports, and then after 1.5, 2 years, it decides I want to play soccer again, and then maybe the knee function isn't appropriate anymore, and then the patient needs surgery. So there are a lot of reasons why a patient would need surgery or not, and it's hard to give like really exact time points that you can decide at, I think.
Xavier, thank you very much for your question. So in terms of your discussion, and I'm sorry to jump forward, but I thought this is a really important takeaway for those that are listening to this journal club. And I'm going to scroll down just enough to make you slightly nauseous. But I'm going to repeat this quote since I can't highlight it. You discussed an approach where clinicians and patients share the best available evidence when faced with the task of making decisions, and where patients are supported to consider options to achieve informed preferences. You know, for us, and we were talking beforehand, I think this is a good way to talk about evidence-based practice. And you talked about this approach in your methods, but then you come back to it in your discussion. Can you discuss this a bit more in terms of what this means for clinicians that are having this conversation with patients, and especially when discussing the different options? You know, we talked about levels of function, we talked about levels of pain, et cetera, especially between those that went through a non-operative rehabilitation route versus those that did have a delayed operation. Can you talk about this a bit more? Yeah,
definitely. Yeah, thank you that you pointed this out. I think, we call this shared decision making, and I can only speak for the Netherlands, but in the Netherlands we think, this is really important, and we try to incorporate this as much as we can in daily practice. I think previously what a classic doctor would say is like, okay, you have this problem, there's this treatment, we're going to do that, and that's it. But now we're more, developing towards a more, different approach where we talk with the patient and talk what is important for the patient and what symptoms he experienced and what we can do about it, and also be honest about the different treatment options, because most of the times there's not only one treatment, but there are, for example, 2. In this case, with ACL ruptures, you can choose to first start rehabilitation therapy, or you can decide to do the surgery right away. And I think in that case, it's important that you offer the patient all the information that he or she needs and then come to a decision together. So as a doctor and a patient. And I think this information should contain like all the pros and cons of both non-operative treatment and operative treatment. So because with rehabilitation therapy, you have the risk that in the end you still need the reconstruction. So that's one thing. So then it takes more time in the end. But also with an operation, you have the surgery risks, of course. So that's also a risk. And I think by discussing all those pros and cons of both treatments, you can really get to a treatment that is the best for your patient. And that's the most optimal. And also then the patient knows what he can expect. So it's also a bit of about expectation management maybe. And I think that's really important to get a good treatment result.
Excellent. So, it's such an interesting concept because I think it really also goes back to concepts like health literacy and what a patient feels comfortable having that shared decision making, or if they feel comfortable having that shared decision making with a physician, right? And it really brings in the context not only pain but function, but also sociocultural factors that may also inform this type of decision making and this how comfortable do you feel having this discussion with a healthcare provider versus, yes, I'm going to do what you tell me to do, as you mentioned with the classic doctor model saying, you tore your ACL, you're going to need surgery, let's do surgery, opposed to talking about a more conservative versus more aggressive management. For those attendees, I'm going to go with Xavier or Rachel. I mean, from your clinical experiences and Dr. Van der Graaff, Xavier is one of our doctoral students here at the University of Virginia pursuing ACL research. What are your thoughts on that concept with the shared decision-making between the patient and the provider?
It's definitely interesting. I think that a lot of times it's talked about as it should be a shared decision. And oftentimes I think in practice, it might not necessarily feel that way because if you're a patient, generally you aren't necessarily the most educated on this condition. You may have never thought about an ACL injuries before you tore your own ACL. And then you go to see someone who is a specialist like a surgeon, and most likely a surgeon is going to tell you that you need surgery, not because they're trying to be coercive, but because when you're a hammer, a lot of things look like nails. Whereas if you go to a physical therapist or someone who does do more rehabilitation-based care, they might try to prescribe you something a little bit more conservative first. And so I've seen, especially in Dr. Van der Graaff, I've also worked in athletics quite a bit. And quite often the push in athletics is to get someone into surgery as soon as physically possible with a goal to have them back on a field or a court as soon as physically possible. So quite often, I mean, we're seeing people who have surgery within a week of their incident, depending on how much they swell up. And they might do some rehabilitation, but definitely not months worth. That's why this is so interesting to me, just because I wonder that if in our current medical system here, if we could even try to duplicate something like this with a large enough sample of patients and surgeons, physicians, etc., who would not be very upset with us for even trying to ask this question.
Now, I want to stretch your findings a little bit, Dr. Van der Graaff, and to Xavier's point as well. And one of the concerns you have with ACL rupture is this idea of the aging knee, right, and the development of osteoarthritis, etc. When looking at a more conservative approach, rehabilitation-wise, versus operative treatment more readily, as Xavier mentioned, a lot of our athletes will have that intervention within a week, 2 weeks of injury, based on their clinical presentation. Is there any correlate to delayed onset of a surgical intervention or going the non-operative route and the onset of osteoarthritis that might set individual up for poor outcomes later in life?
Yeah, I'm not really into that data and research yet, but what I remember is that it hasn't been proved that delaying ACL surgery or doing the non-operative treatment leads to more osteoarthritis. And that's the common idea, because if you do not have your ACL, you maybe have more instability moments and you can get more traumatic knee injuries, for example, meniscal injuries or cartilage damage or something like that. But I think it has been proven that just rupture of your ACL is already a risk factor for developing more osteoarthritis in the knee. And and that's not really, it hasn't been proven that that is depending on the kind of treatment that you get. So that's what I know about that. But yeah, it's a logic idea that, yeah, if you have more instability, maybe because you have no ACL, that's why you can get more osteoarthritis, but I think that hasn't been proven.
Right. And I have one last question for you, but our attendees might have more. So I encourage you to ask more questions as you have them. What are the key takeaways that you want our viewers to get from your article? If you're going to say, here are the top 3 things or top 2 things I hope people get from this manuscript, what would they be?
Yeah, I think first main important message is that by this study, we really looked into an RCT, like a randomized study population, and then looked like what are the reasons for performing ACL surgery. So I think the 3 most important things are like the low IKDC score, instability concerns of the patients, and the pain. So those 3 things you can keep in mind while maybe checking patients with an ACL rupture. And also what's important, I think, is like talk to your patient, like what complaints is he or she experiencing, and what does a patient want with his knee, what is his desired activity level. Those are all things that matter in terms of if you really need an ACL reconstruction or not. I think that's really important. And also we didn't talk really about that, but at baseline, we also found some differences between the groups, and mainly that was that patients that needed ACL reconstruction in the end, so that failed their non-operative treatments, they were significantly younger and had a higher activity level. So already at baseline, you have maybe some indicators that a patient may need a surgery. Compared to an older patient with a lower activity level. I think that's also important to take from the study.
You know, one of the things that I would say that I'm taking away from this is really stressing the importance of patient-reported outcome measures as well. I think you pointed out a key fact of your data that we have to be very cognizant of is, yes, that we do see this inflection point over time with the IKDC, but also pain scores, but your sample size also reduced, you know, over the period of 24 months. But again, these patient-reported outcome measures are free to use. They're relatively brief to complete, and yet they can inform your clinical practice and your conversations with your patients moving forward. And I think this is one of the first, and Xavier might correct me on this, but one of the first articles in a long time where we talked about ACL reconstruction, and it was solely based on patient-reported outcome measures without more objective strength, range of motion testing, et cetera. So, and Xavier might correct me if I'm wrong on this, but at the same time, I think this does a nice job of saying, like, even with a to complement the clinical examination, the importance that patient-reported outcome measures can play in the clinical assessment. And Xavier, I saw you unmute yourself briefly.
I think we see a lot, yeah, like you of papers that include PROs as companions to other things or as companion papers, so they're part of a larger study. But I think we are seeing a growing body of literature that uses maybe less PROs, but it's very qualitative and interview based, like small samples, and trying to get into some of the more subjective feelings of patients. I actually had one question, and just essentially about the rehabilitation protocol. And so I saw you referenced the Dutch guidelines. Were the rehab protocols very different for the non-operative group than the operative group, or was it still essentially progressing along based on criteria to try to achieve the same tasks?
Yeah, I think it's more or less the same because yeah, we have this Dutch ACL guideline, and that's about like what treatment should you do, what kind of grafts would you. It's very broad. And about exercise therapy, it says that exercises should focus on balance and proprioception. And I think like that's the similar for patients that got the ACL reconstruction and then do in our country, it's 9-month rehabilitation program, or if you have your ACL rupture and then start rehabilitating with your rehabilitation therapy, that there are more or less the same exercises, but the compare trial was set up as a more pragmatic study. So we just gave the opportunity to the physical therapist to like adapt their physical therapy program for the patient depending on his knee status and his level. So there were no strict exercises or number of repeat of the exercises, that kind of things that we forced onto them. So it was really pragmatic.
Great. Well, with that, my questions are spent. You've addressed every one of my questions very well, and I appreciate your thorough responses. And also, I appreciate our attendees for taking the time to visit today. So on behalf of the World Federation of Athletic Training and Therapy, Dr. Graaff, we thank you for participating in this journal club. And we look forward to hosting our next journal club, which will be, of course, happening in April. And we'll be discussing lessons learned in academia related to athletic training and therapy as they relate to the pandemic. So again, Dr. Graaff, thank you so much for your time and sharing your expertise with us today. And for those that want to share this recording, this will be posted on the World Federation of Athletic Training and Therapy website, so WFATT.org, and that can be accessed probably by the end of this week. So again, Dr. Graaff, thank you so much for your time and sharing your expertise today.
Yeah, thank you very much for having me. I really enjoyed talking about this paper, and thank you for attending.
Thank you.
And I'm going to stop.